let's talk a little bit of use of scoring balloon in complex PCI. Um, why the need for scoring balloon? Why the usual balloons that we've had in the past are not are not good enough? I think tight lesions, very tandem lesions, spot lesions. A lot of times, especially if it's fibrous or calcified balloons, especially fibrous lesions, tend to slip a lot. So, scoring balloon gives you a little bit more control and reduces the balloon slippage. Um, a lot of times, we're passing nowadays they're long stents, for 4.8 cm, and previously we had 6 cm stents, and where long DCBs or stents cannot cross. So preparing these lesions better with a scoring balloon allows us to deliver the devices better, and even in calcified lesions where we get away without using an atractomy system because of the scoring balloons give us good predilatation results and allows the stent to expand adequately and overcoming this mild to moderate so-called calcified lesions. Of course, in ISRs where the lesions mostly are fibrotic, scoring and cutting balloons really do a great job. In osteal and bifurcation lesions, I feel as well. Because a lot of times, if you use the hybrid sort of PCI technique, you want a DCB the side branch and you understand the main branch. Preparing these lesions, the osteal lesions with a scoring balloon and maybe a DCB gives great results in the end. So, when you use a semi-compliant balloon in a tough lesion, a lot of times you have dog boning. So, and what happens in dog boning is the end of the balloon sometimes damage the vessel, and you get bad dissections and you start running into trouble. So when you have a scoring balloon, especially a non-compliant platform, you get a uniform pressure, and a lot of times you concentrate the dilatation at the lesion site, and you get good pre-dilatation results. So scoring gives a very focused force. If you look at this example that they've given in our OCT, using our OCT, scoring balloon is very predictable to give you a very controlled dissection, and then thereafter you're able to treat the lesion whichever way you see fit, whether it's a drug coated balloon or a stent, or whichever way you feel you want to move forward. Now, in the past, of course, a lot of us who've been doing this quite some time will be familiar with angiosculp, the Wolverine, which previously was the flex dome, and the newer kids on the block, so-called to speak, are the NC score flags, and then the Wedge had a semi-compliant platform, but now they have a non-compliant platform, which I'm very happy they did. They decided to bring the NC platform, which is wonderful. And of course, sometimes we also use the NSC Alpha, which uses 3 wires. So why Wedge NC? I mean, that's why we are here. We want to talk about Wedge NC. So the one thing I really like about Wedge NC is how high I can go with the NC platform. The rated burst is about 22, if I'm not mistaken, and we can go up to 28. And I have gone up to 28, 30 without having any problems with rupture and so on. But then as we go along, we will speak more on how to safely go to these high pressures without running into trouble. And they also have the smallest scoring balloon, which is about 1.5 mm, right? So then again, the indications for usage of scoring balloon, I think as we go along, we will see a sample of a few cases, and we will discuss the pros and cons and whatnot. So like I said, the RBP is about 22, and you can go up to 28 atmospheres, and they've got a range of balloons, all sorts of sizes, which is really interesting. And one important thing about the Wedge NC that I really like a lot is the crossing profile, which is second only to our semi-compliant balloons, and that's amazing. And you're able to deliver it to a little bit tortuous lesions, distal lesions, with not much effort. So I would like to share a few cases just to illustrate what I've been talking about. Feel free to stop me at any point to ask me any questions. I have the first case, a 69-year-old lady, diabetic hypertensive dyslipidemia. She presented with some chest pain and dyspnea. LV function was preserved. So if you look at the coronary angiogram, she's got a severe disease in the osteal LAD, and we felt that we could argue that maybe you can stop at the ostium, but we felt that because there was some disease in the body of the left main, and essentially IVUS proved that as well, we felt that we have to go to the ostial. And if you can appreciate, there's a little bit of calcification. We're not a 360, probably about 90, close to 180. And we were hoping that, because it's a large vessel, we can avoid arthrectomy, hopefully a scoring balloon too. So that's what we did. If you may appreciate, because we put in an IVUS, we knew the size of the vessel was huge, 4.0 in the LAD and a 4.50 in the left main. So we actually used a 3.5 NC wedge straight away. And you can see that on the first image on the left-hand side, you can see the dog boning giving way at about 18 to 20 atmospheres. And thereafter, we stretch the ostium, which was very important to make sure the lesion preparation is adequate. We went up to high pressures without any problem, 22, 24 atmospheres. And, after pre-dilatation, we achieved very good results in terms of pre-dilatation. We were quite happy. And thereafter, we proceeded to stent. In fact, there's one small thing missing here, is that actually we pre-dilated the left main lesion with a 4.0 wedge, which I missed to put in. We actually did that. And the last image I showed you was after that. So we felt that we'll achieve good stent extension and a good MSA, and we were quite happy. So we put in a 4.020 in the mid to proximal LAD and a 4.0 Megatron because I wanted to stretch the stent adequately in the left main. And I managed to do just that. Post-dilated the left main with a 5.0 high pressures, 22, 24 atmospheres, and LAD with a 4.0 NC, and then we achieved very good results, I would say, and we were quite happy with this. So, in this case, there was a little bit of calcification. We managed to overcome that with scoring, very controlled dissection. We were not too worried about the circumflex. We knew that the ostium was good. We're not going to run into any trouble. IVUS also showed very good MSA. Now, second case, 79-year-old gentleman, hypertensive, also has some prostate, came in with very typical angina and a positive dobutamine stress echo. Echo shows 40 EF of 40% with anterior WMA. So this is corneal angiogram. If you may appreciate, there's quite a bit of calcium in the proximal LAD running up to the mid LAD. Initially, because there was a tight lesion distally, we were debating whether we should use a rota system or a orbital arthrectomy. And we felt that if we took a rota system, we might not be able to touch the calcium in the proximal. So we decided to go with the orbital arthrectomy. And that's what we did. We had a little bit of trouble initially, but then, once it went through the distal tight lesion, we made multiple runs, did high speed at the proximal. And this is post. We felt that was adequate. So in this case, this is a post-arthrectomy. So there could be an argument, why not just use an NC? But if I have an NC scoring, why not? Because a lot of times with long lesions like this, not in this case, but in long lesions, we do a hybrid with DCB, the distal, stent the proximal, and then, we get out with quite good results. So we initially took a NC 2.5 wedge, balloon opened beautifully. And then we upgraded a 3.0. You can see that the left main to LAD proximally, there's still a little bit of dog boning. We're not very happy. This is after the 3.0. So then we went further, took a 3.5, went at very high pressures. The dog boning has actually somewhat disappeared. Excuse me, sorry. The dog boning has somewhat disappeared. And last video is not playing. Anyway, so just 1 second, yeah. It's okay. I mean, this is that video is a post-dilatation video just to show that we have achieved good pre-dilatation, and we're quite confident that we are able to deliver any stent and achieve very good stent expansion. So, he was a 79-year-old. We debated whether we should put a DCB. I mean, that last video would have shown that, why we were talking about DCB, because we achieved such good results. We didn't see much dissections distally. But then we thought he's a 79-year-old. Let's not muck around. So we took a 3048 DS, and then we proceeded to the left main with a 3528. The reason why we use the Megatron is because the left main was a 5.5 vessel. So hence why, so we post-dilated the left main with a 5.5, and then the rest of the system with a 4.0, and this is the final result. We lost the first diagonal there, but it's a very small branch. Otherwise, excellent results. So, I'll go straight to the third case. A 36-year-old young gentleman, hypertensive dyslipid, preserved LV function, presented with recurrent angina. Drop was negative. So his angiogram shows his circumflex and RCA were pretty pristine, but he had a totally occluded LAD. So single vessel, we went ahead and crossed it. Was not really a difficult lesion, to be honest. Pre-dilated initially with a semi-compliant, and then we used this 275 scoring. I mean, there could be a huge argument here that, look, it's a male, young 36-year-old male, probably is a 3035 vessel, but the idea is, this is a young chap, totally occluded lesion. The idea was I wanted to put a drug-coated balloon and see how it looked like, and hence why I undersized it a bit. I mean, probably these were slightly during my slightly younger days, not that I'm too old now. So, I chickened out a little bit, used the 275 scoring, put a 25 DCB in the diagonal and a 275/40 in the LAD. And these are the final results. I accepted it. Very young chap, brought him back after about 8 months. And you can see how nicely the vessel has remodeled, and excellent results, beautiful results. So that's about the cases that I want to share. So the three cases that I shared, in my opinion, how I use NC pre-dilatation balloons. I think especially when you're dealing with calcified lesions, I think the other speakers will go through this as well. Lesion preparation is the most important. You never want to deliver a stent when you're not happy with the lesion preparation. You want to make sure the stent will open adequately. You don't want underexpanded stent which you cannot expand adequately, and you run into trouble later on. So I think the scoring balloons, especially on our NC platform, gives us an advantage in this scenario. And also with the scoring balloon, supposedly they're bulky, but in this NC wedge, especially, when your crossing profile is pretty good, you're able to deliver it, and you're able to prepare the lesion adequately to be able to deliver whatever devices, stents or balloons that you want to deliver. And scoring balloon also gives this added advantage of a controlled dissection, especially those who are believers of drug-coated balloons, or those who use very diffuse lesions, who use hybrid sort of strategy. So I just tried to put forward 3 scenarios where where scoring balloon, how I use scoring balloons at least, as the examples and bumples. I hope that would help. I will take any questions now along the way or once we are done. Thank you.